Hello everyone, to those who just joined us. We are delighted to invite you to this webinar, a webinar that's jointly organized by the World Health Organization, the Eastern Mediterranean Regional Office, and Sanad, the Home Hospice Organization of Lebanon. And I am Farah, the Head of Quality Research and Development at Sanad, and I'll be moderating this webinar with you today. The focus of this webinar will be on how palliative care services responded during COVID-19. And we have another webinar on Monday that will focus on policy and advocacy aspects in palliative care. We wanted from this webinar to create a platform for healthcare providers and the experts in palliative care to share their experiences, lessons learned, challenges while responding to COVID-19, and to highlight how these experiences can inform policy and advocacy level efforts so that we try to strengthen palliative care at the regional and national level during the pandemic and beyond pandemic. We want to take this advantage, the advantage of having COVID, to strengthen integrating palliative care into the healthcare system. And we are aiming from today's webinar to inform the policy webinar on Monday. So we are looking forward to a fruitful discussion. During today's webinar, our distinguished speakers will be able to present for 10 minutes. We will be having 7 presentations. And after the presentations, we will be having a panel discussion where we share how can we maintain current palliative care services and better meet the needs of patients with COVID-19. Just to tell participants how will this flow. So participants will be able to join us via the chat function. Please write down your questions, your comments, and we will be going through them. We will have multiple sessions of Q&A in between the presentations, and we will have a final Q&A after the panel discussion as well. Just for the sake of keeping track of time, and we will be tracking the presentations, and I will be reminding you whenever there's 1 minute left, so that we reduce the load on the webinar, try only to keep your cameras open for the speakers during presentation and during the discussion as well. Let's start with our first speaker. I'm happy to introduce Dr. Nassim Forgazian, Technical Officer of NCDs and Cancer at WHO Eastern Mediterranean Office. Dr. Nassim will present the current situation of COVID-19 in the region and the WHO's effort to incorporate palliative care in healthcare response to COVID-19. Thank you, Dr. Nassim.
Thank you, Farah. Thank you very much. First of all, again, thank you to the colleagues in Sanad for this great collaboration. And thank you to all of you who have joined us this morning. I'm really humbled to be among so many palliative care professionals and supporters today. Although I'm not a palliative care doctor myself, I'm a medical doctor who used to work clinically in Sweden before joining the regional office of WHO 3 years ago. And although not a palliative care doctor myself, I've had the privilege to work on this portfolio and to closely engage with a lot of palliative care professionals in the region during the past years. And I would like to just add that I have a tremendous respect and admiration for palliative care. And although these past months have been difficult and dark in terms of the clinical weight and the difficulties in the work environment for many professionals, I also think that it has shed a lot of light on the importance of palliative care. So without further ado, I'll put up my presentation. Let's see here. There, can you all see my screen? Farah, give me a thumbs up if you see my screen. Perfect. Okay, so as Farah mentioned, I'm not a palliative care professional. I'm a technical officer at the regional office. And I would like to just give a brief overview of the palliative care work that we've done in the region during the past year, some of the developments. I'm not going to go into the details of COVID because we are all bombarded with information about it every day, but just to set the scene a bit for our discussions. So I would like to just start by setting the policy context for the PC agenda at the global level. In May 2014, the World Health Assembly adopted the Resolution 67.19 on strengthening of palliative care as a component of comprehensive care throughout the life course. This is a very important document because it calls upon WHO and member states to improve access to palliative care as a core component of health system, and it emphasizes primary health care and community-based care. Also, WHO explicitly recognizes palliative care as part of the comprehensive services that are required for NCDs, but also other diseases. Some quotes from this resolution: recognizing the need for palliative care across disease groups, NCDs, infectious disease, including HIV and multi-drug resistant tuberculosis, and across all age groups. Realizing the urgent need to include palliation across the continuum of care, especially at the primary health care level, and recognizing that inadequate integration of palliative care is a major contributing factor to the lack of equitable access to care. And this resolution also welcomes the inclusion of palliative care in the definition of universal health coverage and emphasizes the need for health services to provide integrated palliative care in an equitable manner. Now, this is important because 194 member states have endorsed this, and this is something that we can hold member states accountable for. The resolution urges member states through 9 different points what they need to do to make palliative care an integrated part of their health systems. Secondly, I just want to give a snapshot of the COVID-19 situation in the region. As of the 23rd of July, there were over 1.4 million confirmed cases and 36,350 deaths in the region, with the highest number of cases and deaths being in Iran, followed by Saudi Arabia and Pakistan. In the graph, you see the daily cases, the evolution of the number of daily cases from February to date, showing that we are still in the midst of the pandemic response. 2 months ago, there was a rapid assessment done where a 12-question web-based questionnaire was shared with ministries of health to assess NCD service disruption and mitigation strategies during the pandemic. The assessment had an 80% response rate in EMR, and although I'm noting that it's focused only on NCDs and does not reflect all essential health services, it did find a severe disruption of essential health services due to a set of factors, some of which are closure of in- and outpatient facilities to reorient care, insufficient staff, beds, and of course, protective equipment, as well as stock out of essential medicines, supplies, and technology. The main mitigation measures in countries of the region included triaging to identify priorities, novel supply chains, but also new dispensing mechanisms for medicines, and of course, different telemedicine solutions. So as you all know, WHO's work has been heavily shaped and affected by the pandemic response during the last 6 months. Although there's a lot of guidance and tools related to COVID-19, I just want to briefly present 2 important documents related to COVID-19, which also include explicit reference to palliative care. The operational guidance on how to maintain essential services in the COVID-19 context is a key document on how member states can make modifications to the health system for safe delivery of services, as well as how they best transition towards restoration of services. Palliative care was included in the updated version of this document and provides guidance on how to modify services and transition towards restoration, as shown in the 2 examples. Another key document is the interim guidance on clinical management of COVID-19, which includes a section dedicated to palliative care, emphasizing on a set of ethical, clinical, and health system considerations for palliative care in the context of COVID-19. There is also a set of previously developed palliative care documents, and we actually have the lead in headquarters who couldn't be with us today, but they will present more details on the process and how it has really highlighted the importance of palliative care in the response. She will be with us on Monday during the next webinar. But to give example of some of the other palliative care guidances that she has been part in developing, there's one on integrating palliative care and symptom relief into the response to humanitarian emergencies and crises, which of course is very, very relevant for what is going on right now. There are also other documents on integrating palliative care in primary health care, how to plan and implement services, specifically targeting program managers, and how to integrate palliative care and symptom relief in pediatric care. Just briefly want to mention that a global working group on COVID-19 and NCDs was established in March, with the objective to improve the global understanding about the pandemic and the intersection between NCDs and COVID-19, to enhance global coordination, strengthen communication, and to provide technical expertise and guidance. The main aim of this working group is to align normative work and country support across the 3 levels of WHO, and it has led to the development of 8 separate global working groups, as you can see in the below squares. I just want to indicate that out of these 8, there are 6 groups that have work directly related to palliative care, and for which the outcomes can be relevant to how we also move forwards with palliative care work in the context of COVID-19. So to move a bit to our region, I would just like to give an overview of palliative care in our region. You know it best on the ground, but just to give you a bit more of the policy context and what recent developments have been made. So as you know, when we talk about the region, we talk about the 22 member states, from Morocco in the west to Pakistan in the east and down to the Horn of Africa. These countries are very diverse in terms of their income levels, health system maturity, but also the socio-political context that have a direct effect on palliative care service provision. So access to palliative care is a major challenge. I don't need to tell you that, but based on the Global Palliative Atlas estimation in 2014, only an estimated 5% of adults in the region who are in need of palliative care actually receive it. Palliative care services has also been included and reflected in one of the in our regional framework on cancer, which has been endorsed by our member states and has one complete section out of 6 focusing just on palliative care, how to build the capacity, how to ensure that essential medicines are available at national level. Data and documentation is always a challenge. But in 2017, colleagues at Navarra University, together with the Lebanese NGO Balsam and some other colleagues from the region, developed the Atlas of Palliative Care in the Eastern Mediterranean, which you can see on the picture, which gives an overview of palliative care activities across the region. Right now, we also, the regional office, together with the University of Navarra and Professor Carlos that is with us today, are working on a project to define a set of regional indicators to continuously monitor progress. I also want to mention a regional network on palliative care that we have, and many of which are with us today. We had a first regional expert meeting on palliative care in Beirut last year, and it brought together experts from across the region. The aim is to create a forum for regional exchange and collaboration, just like we're doing here today also. So the network today includes experts from 14 countries of the region, and we envisage this network to be on a rolling schedule. So we actually, members will be exchanged every 2 years. So we will go by biennium. The main aim of the group is to guide the regional office on how to operationalize the WHA resolution I showed in the very beginning. And the group has developed and agreed on a regional roadmap for the coming 2 years with a set of deliverables. These deliverables are across 3 main domains: policy, human resources, and service delivery. And there are a set of deliverables that are being developed as we speak: policy briefs to push the agenda, a regional curricula for building capacity of palliative care capacity at national level, but having a regional base in common on how we develop that, and a set of service delivery related deliverables. So for today's webinar, I think that we have a great opportunity to hear out what our experts in the region and the area have done, how we can exchange experiences, learn from their experiences on the ground, and translate that into policy action. So some opportunities that might be ahead of us is the fact that, as I said in the beginning, palliative care services and the importance of building the capacity has really been highlighted during the past months. We have an increased awareness and understanding, not only among clinical colleagues, but also in the public. There might be advocacy and fundraising opportunities. We might be able to identify and create governance space for palliative care at national levels, which in turn can lead to strengthening integration of palliative care services and to integrate palliative care in future national pandemic preparedness and response plans, so we don't find ourselves in the same situation again. And last but not least, to document the experiences from this period so that we can use it for advocacy and policy action as we move ahead. Thank you. And I would like to just finish with this last quote from a palliative care doctor at Duke University who has done a very beautiful cartoon series on palliative care and COVID-19. And he rightly says this: as we take stock of masks, gloves, and ventilators, we must also be ready to dig deep into our reserves of patience, communication, and compassion, something that I think that palliative care professionals are the absolute best in doing. Thank you.
Thank you, Nasim, for all the interesting information presented and for highlighting the WHO effort and always trying to push forward the palliative care agenda worldwide and also regionally. We'll move forward to our second speaker, Dr. Sabah Boukhid. Dr. Sabah is a research associate on global health at King's College London, Cicely Saunders Institute for Palliative Policy and Rehabilitation. Dr. Sabah will be presenting the preliminary findings of a rapid assessment that was conducted by a research team on the level of preparedness of hospices and palliative care services in the Middle East region. Thank you, Dr. Sabah, for accepting our invitation to present and for sharing such an important information during this time of COVID.
Thank you very much for the invitation to speak and to share our findings. I'm going to try to share my screen right now. So I'd like to present the findings of the preliminary findings of a survey we did with Dr. Omar Shamir from Jordan, who will join us later in the discussion, Professor Tezer Kutluk from HTP University, who is in the audience, and Professor Richard Harding from King's College, who could not make it today. So we conducted a rapid survey, rapid assessment to assess the preparedness to face COVID-19 pandemic in hospices and palliative care services in the Middle East region. And so our rationale was that palliative care is recognized as an essential component of COVID-19 response, but it has been overlooked in preparedness plans like Nasim just highlighted. And the level of preparedness of services in the region is unknown. So our survey tries to gather some evidence on that. So just for the record, maybe I should just get rid of that. Our definition of Middle East region is slightly different from WHO. So I just put a map here, and we included the 21 countries in the map here. So we conducted a cross-sectional online survey, and we used key international guidelines for this work. So the WHO international regulations for preparedness, an assessment in Italy of palliative care services, and international recommendations for palliative care response and roles in pandemics. So the survey was available online both in Arabic and in English, and it had about 9 sections describing the service and the COVID situation in the service, what procedures were in place and what measures and procedures were in place, what are the communication and coordination situations, what are the resources, the perceived effects of COVID on staff and the risk for the service, and the potential for the services to support the wider health system. So we use convenience and snowball sampling to recruit representatives of palliative care services in the region. So to recruit these representatives, we use several sources for recruitment. So we listed all available contacts from the atlases of palliative care. So thank you very much for those who did this work. We used the directory of the International Association of Hospices and Palliative Care, and we conducted a rapid search on Google and looked at publications on palliative care in the region, especially for countries for which we did not find many contacts. And we also used the network of our investigators, in particular in Jordan and Turkey. So we sent the survey by email to associations, organizations, and representatives. So we ended up having 43 respondents included in the findings I'm going to share now. So we had 12 countries who did give a response. So in dark gray, you can see that we could not find contact for Libya and Syria. In light yellow are countries where we did not have responses. In light gray, we had 1 to 3 responses. And in dark gray, Turkey and Jordan, 10 to 15 respondents. So just a brief description of the participating services. So the respondents' characteristics, most of them were doctors and 1 in 5 nurses. We had 2 in 5 services who responded were public services. The majority of these services were hospital-based, and most of them did provide some additional care. 3 in 4 had beds, and they were seeing on median 500 patients per year. So interestingly, at the moment we sent the survey, already 2 in 3 services had already a COVID-19 case, be it suspect or confirmed, and on median they had 5 cases. The patients were involved in most of cases, but also healthcare providers. Mostly were identified in another service of the hospital, not necessarily all within the palliative care service itself. So just the preliminary findings about service available. So in terms of policy and procedures, 1/3 of the respondents reported having no case definition for COVID-19. However, the vast majority did have written procedures for what to do in case of COVID-19 in the service amongst their patients, staff, and volunteers. So the table below describes the policies and procedures that have been modified in regards to COVID to prevent contagion. So most services did change several procedures, particularly operator protection, policies regarding visitors and relatives, dead body handling, and patients admission. And less services did modify their policies on volunteer support, bereavement care, and do not resuscitate. And I just want to flag the not applicable column on the right for volunteer support and do not resuscitate, which suggests that about 15 to 20% of services did not have these policies, most likely. In terms of infection control and access to resources, the majority, again, of services did put in place infection control measures, did provide additional PPE for palliative care staff and cleaners. It does not mean that it's enough, but they did provide additional ones. They identified isolation room, put hand washing facilities at every point, And I just want to flag that 50% of those who had hand washing facilities had them before COVID happened. The services knew how to dispose of infectious waste, and they were trained in handling highly infectious conditions. And once again, those who were trained, for half, were trained before COVID happened, so already prepared. The majority knew how to access food, medicine, medical supply, and additional stuff if there was a lockdown or a COVID emergency. However, a third of the services reported concerns over accessing basic hygiene products in particular, so concerns over accessing disinfectant, soap, running water, hand sanitizers, but also contactless thermometers and electricity. In terms of information systems and technology available in the services, more than 4 in 5 services reported having the capacity to use technology to provide remote care, especially psychosocial support or bereavement care. They had up-to-date inventory of PPE and medicines, medical supply, and they did know their communication channels in case of emergency. So most of them had a designated focal point to collect and share up-to-date information on COVID, and more than 3 in 4 would use mobile phone as a communication channel. Almost all services had up-to-date lists of patients and staff. Some were paper-based and a good proportion electronic. They collected patients' symptoms, outcomes, and treatment, so it's possible to monitor, and more than 2/3 had electronic records. However, 2 in 5 did not have visitor and relatives' contact details and visit dates, which may be an issue for contact tracing, for example. In terms of palliative care staff and palliative care expertise, so the staff well-being is an important issue that emerged. The staff is highly anxious, especially about getting infected, and anxious about caring for their families and children. However, only half of the services did have a stress management procedures. In terms of how palliative care services could support the health system, we found out that 3 in 5 services had protocols for symptom management and psychosocial support that could be shared with non-specialists. And those who reported having these protocols were ready to provide the non-specialists with training. 3 in 5 services had plans to support other healthcare settings in triaging COVID patients, and about half of services had redeployment plans for their staff and resources. And it's interesting to note that 20% were not sure whether such plan exists. However, once again, for volunteers, 1/3 of services did not have or did not know whether there were plans to redeploy volunteers. So in terms of challenges and lessons learned, so for us, from the research point of view, some strengths and limitations are, it was a rapid exploratory survey conducted during a pandemic. Some services may be represented more than once, and we are only covering those who could have access to internet, of course. It was difficult to recruit rapidly in the region, but we did manage to have 12 countries from a wide geographical range, and we have a comprehensive assessment of preparedness. So for us, the main challenges, some of the main challenges for palliative care in the region would be to build staff resilience and provide support. And also, in case of lockdown, there would be concerns around home visits and community involvement. We found that we only have a limited number of community-based services in our survey, and there were concerns about hygiene in the communities. In terms of opportunities, we believe that there is a good potential to monitor access and availability in opioids in services, a good potential to share protocol for symptom management, bereavement, and to train non-specialists. And there is also a good potential to use technology, for which we would suggest to explore funding and check out whether the patients have resources, because some respondents highlight this may be an issue. And I guess this will be a point for discussion later. So I'd like to thank very much the participants, the organizations and people who helped, and our colleagues. So thank you very much.
Thank you, Dr. Sabah, for a very interesting study that's much needed now, and it really sets the stage now for the whole discussion. And throughout the sessions, we'll be able to reflect on the study as well as the experiences of the palliative care service providers that we have today, and as well during the discussion. We encourage you, dear participants, to post your questions, and we will be taking Q&A after the following session. Now, I'm glad to introduce our third speaker, Dr. Pamela Farah. Dr. Pamela Farah is a medical coordinator at Sanad Home Hospice Organization, and she will be presenting the experience of Sanad, a home hospice organization, in responding to COVID-19.
Thank you, Farah. Good morning, everyone. Can you see my presentation? So I will be presenting the response of Sanad, the home hospice organization of Lebanon, to COVID-19. First, we will start. I'm having a technical problem with the presentation. Okay, sorry. First, we will start with the background about palliative care in Lebanon. Palliative care in Lebanon is provided since 2010. It has started with 2 home-based NGOs, Sanad and Balsam. Lebanon is considered as a level 3A country in palliative care, where we provide isolated palliative care provision under different service models, such as home-based palliative care, consultation teams, units, and outpatient clinics. Palliative care is not only provided to oncology patients, but also to non-oncology patients, and the referral to palliative care is usually done by a physician, whether a primary care or a specialist, and sometimes via the community. In Lebanon, we have a National Committee for Pain Control and Palliative Care that was established in 2011. The access to opioids is regulated by the Lebanese Ministry of Public Health, and the first prescription of opioid needs to be double-signed by 2 different doctors, and palliative care doctors are among the doctors who can prescribe opioid. In 2019, the Ministry of Public Health issued a decree which defines criteria for reimbursement of palliative care at hospital and home-based settings. However, unfortunately, this degree is not yet operational. What about Sanad? Sanad is an independent, non-governmental, non-profit home hospice care organization established in January 2010. Its mission is to provide comprehensive, free of charge, home-based hospice care to advanced chronically and terminally ill patients while preserving their dignity and enhancing the quality of their remaining life inside their home, surrounded by their families. Sanad has 2 offices, one in Beirut, one in Midbika, and we provide palliative care services 24/7 thanks to our clinical and non-clinical teams. We have 3 main clinical units: the medical unit, the nursing unit, and the mental health unit. In response to COVID-19, Sanad modified its operations. We had a contingency management team, and as I said, we have updated our policy while keeping in our minds and while following these guiding principles: preserving the safety and the best interest of the patients, preserving the safety and the best interest of our team, respecting our public health responsibility and duty, ensuring a functional operation from home. Please note that during this phase, we were not taking care of COVID-19 patients in order to be able to increase the number of our own patients and reduce their influx into the hospital. Our response policy covered 3 main categories: the service provision, the infection prevention and control measures, and the office working mode. Let's start with the service provision. This is the first phase of our response. We have updated our response, and I will tell you how furthermore during our presentation. For the nursing team, the first step was doing or conducting a COVID-19 screening protocol over the phone, and this protocol is inspired by the CDC guidelines. Whenever the screening protocol is positive, we have decided not to conduct a visit and ask the patients to refer themselves to one of the hospitals that take care of COVID-19 patients and do the testing. For the follow-up of the patients, we had triaging patients' clinical status for our old and newly referred patients. As I said, this is the first phase of the response. Stable patients, which mean patients that did not show any physical or psychosocial signs, they were stocked with equipment and medications so they don't feel the need to go outside their house. And we were frequently following them via telehealth, over phone call and video calls. Active patients, patients who had clinical symptoms, they were visited at their home while the staff was wearing full PPE. We will go through this into our presentation. They were visited in their homes, and the visits were frequent depending on the severity of the clinical cases, sometimes more than twice per week. Patients in the last 72 hours were visited daily and sometimes more than once per day inside their home. For the medical unit, the policy for the medical unit was parallel to the one for the nursing unit, which means conducting visits for active patients after making sure that the screening protocol is negative. As the numbers here will show, during the phase of COVID-19 and still, we were able to fully operate, and we even had an increase in the number of newly admitted and cared for patients in comparison to last year, while noting that we didn't cause any overload to our staff meet and we didn't cause any burnout. For the mental health unit, the mode of follow-up depended on the urgency of the case of old and newly referred patient. Our mental health unit precised some criteria to define urgent cases. Whenever the case was urgent, home visits were conducted. When the case was not urgent, telehealth support was made if the patient or his family felt comfortable doing so. For the infection prevention and control measures, since we are working in home setting, we cannot control everything inside other people's houses. So it was really important to give clear instructions and educational materials to the families via hard and soft copies. The instructions were adapted from the WHO, and the families were informed about the updated policy of SANAD during COVID-19. For the personal protective equipment, first the team had a presentation about COVID-19, and they had clear instructions about donning and doffing PPEs because, as I said, during home visits, the clinical unit as well as our field officers were wearing full PPE, which means head cover, of course, the surgical mask, gloves, gown, and cover shoes. For the equipment disinfection, we have changed our process, and not only we were cleaning, but also disinfecting our medical equipment with alcohol-based solution before delivering the equipment and at the moment of collecting them while the field officers were wearing their PPEs. For the office kept open daily by our contingency management team. The non-clinical units were working from home. They were doing daily online meetings and providing us with weekly reports. And we were continuing to do our internal capacity building sessions online. Of course, COVID-19 is a new virus. We have limiting resources about it, limiting information, hence we all faced challenges. But on top of these challenges, on top of all the difficulties, it is important for us to show you that in Lebanon, we had a special context, which was due to our limited access to funds because of capital control, economic collapse, and political unrest. So we had limited access and limited availability of certain chronic medications and medical equipment. On top of that, we have had COVID. The non-clinical challenges of COVID-19 was the availability of PPEs. I do believe everyone suffered from this. Plus, we had an unexpected expenditures related to PPEs, to medications, since, as I said, we stocked all the patients with all the medications they were needing. It was not always easy to remotely ensure a daily management of operations on all levels, such as communication, safety, high quality of service. And due to the measures that the government took during the lockdown, the transportation of the contingency management team and field officers were not always easy to be done. Facing the challenges, we had to overcome these challenges in order to keep providing our service for our patients. So what we have learned is that it is important to ensure adequate availability for full PPEs. So that's why we have changed the allocation of our funds. And it is important to always have good communication with the concerned authorities to facilitate our mission and our work, especially during the lockdown. On a clinical level, it was challenging to do telehealth support for patients, either for the healthcare provider and, of course, for the patients and their families as well. And this is due to many factors, such as the inconsistent availability of technology applications among patients and their families, the limiting remote assessment because the physical assessment over the screen is not the same as being actively present with the patient, the difficulty to assess family dynamics. It is not always as easy to do direct psychosocial support when you do not have a direct interhumane interaction, especially more difficult when there is children or elderly. And sometimes families or patients were resistant to using telehealth for support. Moreover, it was difficult to honor our patient wishes, especially such as seeing a family member or visiting a place. And the change in our culture and social traditions in mourning and grief had a huge impact on the families. How to overcome these challenges? We have always to respond to the field and adapt and change our policy accordingly. So we have seen that it was important to conduct at least one first assessment visit for newly admitted patients in order to be able to do a comprehensive assessment, to keep on conducting home visits for stable patients once per week. It is important to give detailed instructions and steps to use telehealth, not only for the healthcare providers, but also to patients and families. As I mentioned, we were fully operational during COVID, and what we believe, if I may say so, the key elements for our successful response are the following: an early preparation, a quick response, and a comprehensive participatory response are keys in order to be prepared to face all new challenges, as well as keeping a close monitor, not only to the policy and be able to update it during the procedure, but also to keep a close monitoring on the safety and disinfection measures. It is important to reallocate funds, give priority to the safety of healthcare providers and to our patients, and it is important to have a stock and to prioritize providing medications and medical equipment to our patients. We already knew that our staff has high qualities, but during COVID we could witness more and more how much they are devoted to their job, to their mission as healthcare providers, how they were resilient in doing their jobs, ability to adapt to all situations and to work in challenging situations. And of course, the office had and the contingency management team has provided us with a compassionate, supportive environment where everyone felt safe doing their job and ensuring a communication among all the team members. It is also important to rely on the community. We have had an emergency fundraising campaign, and the community showed us love and support in providing whatever we needed, such as alcohol-based sanitations, PPEs, and medications. I would like to end with these photos of our lovely team during their missions wearing all their PPEs, and there are some quotes and testimonies from patients and families to show us with overwhelming words to show us their support and how thankful they were for providing this service. Thank you so much.
Thank you very much, Pamela, for this great presentation. It's really amazing to hear about the country level work and what's going on. I think just in the interest of time, we'll move on to our next presentation, who unfortunately the speaker cannot be with us today. I checked several times among the participants. It's a presentation from Sudan, Dr. Nahla Ghafer, who is a clinical oncologist at the Khartoum Oncology Hospital, and she's part of the regional network also. Unfortunately, she cannot join us live due to a lot of electricity cuts and connection difficulties, but I think that her presentation and her work in Sudan is really important for us to take part of. So we found a creative solution where I have an audio note from Dr. Nahla and her presentation. So I'll put that up from my end, and I'll try my best to sync everything, and I hope the sound works well. So I'll just start off by putting up her presentation. Farah, can you just indicate if you can see the slides? Perfect. Okay. So I'll do like that. And then I need to find Dr. Nahla. So I can mention that she's not only part of our regional network, but also some African palliative care networks, which is of course an important bridge in terms of exchanging experiencing and knowing what's going on the ground. And Sudan is a country that moved from only having capacity building activities in 2006 to a country with limited provision of palliative care in 2011. And there are currently 3 different hospitals where palliative care is provided. And part of that development is, of course, thanks to the dedication and work of Dr. Nahla. So here we go.
Hi, everybody. It's a pleasure to join you today. I'm Dr. Nahla Jaffer, a clinical oncologist from Khartoum, and I'll be speaking about COVID-19 response in a hospital setting. We'll be speaking about the importance of integrating palliative care and oncology from the moment of diagnosis, what our services looked like before the corona epidemic, the period when everything was almost closed, and our current situation. Why do we have an integrated oncology and palliative care unit? At the oncology hospital, most of the patients come from other states, from rural areas. They have lower levels of education and they present with advanced disease. That creates a huge need for proper symptom management, the need to address the different social and psychological issues with good communication skills. The unit has seen more than 6,000 patients, and several audits and studies showed improved outcomes to the patients in different stages of their disease. So what did our services look like before the outbreak? Situated within the oncology hospital, we were receiving patients referred from other oncology units within the hospital, as well as patients from other hospitals, especially from surgery. So we had this mixture of patients sent for end-of-life care in addition to newly diagnosed patients. That helped reduce the stigma. Then we have the outpatient clinic, which was held twice a week. There we see like 100 patients per week. We have a 10-bedded ward and a limited home care service, usually on a Saturday. In March, we had a few corona patients in the country. The hospital started to set some regulations. At the palliative care unit, we had our internal regulations. We managed to implement distancing, repeated disinfection of services, and we stopped visitors to the wards. In Sudan, usually when a patient is admitted to a ward, 4 or 5 people would like to stay with him all the time. So we had to stop all that. Another important thing we did was to educate and speak with each patient and carer who came to the clinic. We told them that the disease is real, that it is important to protect themselves and how to protect themselves. Then suddenly, the hospital closed completely for 2 weeks. Most probably there was a case of corona somewhere. We had, unfortunately, patients running out of their pain medications for these 2 weeks. And I remember I had to advise one patient by phone to use diflunac, potassium, and paracetamol instead of morphine. Even after that, after these 2 weeks of closure, the country is starting to reopen slowly. Still, public transport was absent. The bridges were closed, so you cannot go from one part of the city to another part without permission. And we had to advise some patients to ask a relative living in the same part to come, same part of the city to come and pick their medications. Then they had to figure out how to send this medication to the patient. Maybe they find a neighbor, a doctor neighbor, because doctors at that time had permission to move around. Large part of the hospital was still closed. We asked, in the palliative care unit, we asked for permission to work at least once a week because we had patients who were having medications. And the hospital administration gave us this permission. So we come once a week, mainly to see a few patients, like 10 to 20 patients on that day. and we try to give them a good supply of medications, like 2 or 3 months supply of their medications, as well as we carried out a lot of follow-up by phone. So we were having access to the files of the patients, and so we were ringing these patients and asking them their symptoms and managing their symptoms remotely. One of these calls, a nurse, a trained nurse, she detected the patient who was starting to have headaches and hemiplegia. She advised for them to have high-dose dexamethasone. She asked her to do a CT scan, and the next day she booked her for urgent radiotherapy to the brain. So the impact of the pandemic on the country was huge, and it was even huger on the health system. A lot of hospitals were closed. We didn't know which hospitals were open. People didn't know, and they spent a lot of time driving from hospital to hospital, sometimes to 11. Patients were taken to 11 different hospitals without one of them accepting to see the patient. There was an increase of deaths from all causes. So people were dying from corona, from other diseases, and from no diseases, maybe due to the psychological impact of this shutdown. Essential medications were lacking in the pharmacies, like antifungal drugs. Sometimes even dexamethasone is not there. And the public were not believing about the disease. And they were, of course, since they are not believing about the disease, they were continuing, handshaking, visiting, and even to the degree of becoming angry from other people because they don't shake their hands with you. There is an increase in crimes, especially theft. Now we are almost reopening. We are allowed to work from 6 in the morning up to 6 p.m. or these hours, 12 hours of movement. And there's increased publicity on the TV, on the radio, all around. And also the people have seen by their eyes, they have seen relatives or neighbors who got the disease. And so people are more aware, they are conscious about the disease, and they are more compliant with the preventive measures for COVID-19. So, for example, when you answer a call, immediately a voice message comes and it speaks about the corona and some songs about it. لو نغسل يدينا كورونا ما بتجينا. At the palliative care unit, we continue coming once a week. The hospital is providing us with transport. We use masks. There's social distancing. We use disinfectants regularly. We continue educating the patients. Only the patient or carer, only one of them is allowed in the clinic. Still, the inpatient ward is not open. We are waiting for further direction from the hospital administration. There is a plan to increase home care services, especially since we come to the hospital once a week, so we have more time with which you can go and see other patients. And there is a plan to help provide palliative care to COVID-19 patients and their families. That is through the State Ministry of Khartoum. Thank you, and I hope with our joint efforts we can do more. Thank you.
Thank you to Dr. Nahla. It's a pity that we cannot have her with us and have her part of the discussions. And it's really admiring to hear the work that they carry out despite all the challenges and difficulties. I hope that the sound worked well.
And thank you, Dr. Nahla, again for all the effort to send us in recording despite all the challenges that you're having in Sudan. It's a great presentation. So we'll move to our next speaker, Dr. Amina Al-Ansari. Dr. Amina is a palliative care consultant at Kuwait Palliative Care Center, and she'll be presenting to us how did Kuwait Palliative Care Center respond to COVID-19 during the past months. Dr. Amina, the floor is yours.
Thank you. Hi, everyone. Today, I want to share with you our experience about service to COVID-19 in Kuwait. So we will start with a brief description of palliative care services and availability in Kuwait. Palliative Care Center under the ministry, you can put this, the second slide. Hello? Can you hear me? Okay, so Palliative Care Center in Kuwait is under the Ministry of Health. Is a tertiary center providing palliative care services for cancer patients as palliative patients. Our physicians have many different specialties, skills like internal medicine, oncologist, family medicine, supervised by a palliative medicine specialist. All the staff in Palliative Care Center received an appropriate training for palliative care. So we have also an interdisciplinary team, including bedside physicians, nurses, physiotherapists, social worker, psychologists, nutritionists, and pharmacists. And all this interdisciplinary team during this pandemic event is working as a full staff and full service in the last 5 months. Every cancer patient in Kuwait has the right to access to all medication he needs. But for Kuwaitis, they receive it for free. For the non-Kuwaitis, they just pay a very simple fees for this. But they have the right to receive all medication, including opioid. Patients referred to us from all over Kuwait, from all general hospital, the Kuwait Cancer Control Center, and by special consultation form to evaluate either by ambulatory patient service or outpatient clinic service, according to the patient condition. And there is a bi-directional interaction between us and other specialty in Kuwait. They consult us for symptom control, and we consult them also to treat other issues in our cancer and palliative patients. And there's a continued and an easy access to palliative care services through phone calls and WhatsApp. Okay. So due to COVID-19 epidemics, many policies and protocols are emerged and updated regularly according to the clinical situation. As you know, this is a new issue in the world, so it's a new experience. Every now and then we update our policies. I attached a copy of the latest form, and I don't know if we can share it later on or not, from the Ministry of Health. Okay. And number of wards were decreased. In our center, there was 3 wards for palliative patients. But after this epidemic, there is only 2 wards. One of those 3 assigned for COVID patients. But actually, we are using it just for the diagnosed patient. It's a transient ward. We put the patient for isolation. Then we transfer to the COVID hospital in Kuwait. And all rooms are private, and only one caregiver at a time allowed to be with the patient in an alternative way. So we decrease the number of patients and caregiver in the room at the same time for the infectious. Then the palliative care patients were followed up regularly, either over phones or in the OBD or in the Kuwait Control Center, okay, by our team. And training received about the use of PPE, how to wear, how to remove, and how to take care of your stuff, because PPE is not that availability worldwide. We have enough in Kuwait, but we have to keep an eye on how to use those PPEs. And we have also training about how to take a swab for our staff and for our patients. So we have a team, COVID team in our hospital. They do the swab for the patients and the staff regularly and according to the symptom. The staff were divided in 2 teams, alternating on weekly basis. So this will decrease the overlap between staff. Each team is covering the OBD, the outpatient, the palliative care center inpatients, and the outpatient consultation in Kuwait Cancer Control. Those are for symptom management in the Cancer Control Center. But the inpatient, those are the palliative care mood patients. And also in General Hospital, we have a mobile team for consultation outside the palliative care center. Next. And fix assigned staff for each services without any overlap or rotation between the staff or the services to allow proper tracking of any infection and to prevent cross-infection. This policy is initiated since March and still ongoing. 3 of our palliative care physicians were assigned under the main COVID-19 unit in Ministry of Health, but only one of them is working with cancer patients with COVID-19, and he is assigned in a special hospital for COVID patients. He treats only as a symptom control for those patients. In palliative care center, 2 patients diagnosed with COVID-19, 1 patient with severe respiratory distress and died within 24 hours of positive swab, and the other patient was asymptomatic and referred to palliative to COVID-19 ward for observation. He's still alive, he's doing well, no symptom rather than he lost smell. And if any staff has suspected or confirmed COVID-19 and in a quarantine, another staff will replace him to avoid any work disturbance. All the services are working continuously since March. All medicine supplies and PPE were available either from government sector or from NGOs. Referral system is nearly the same except for palliative with confirmed COVID-19 in other general hospital. They are interviewed through the video calls. Next. In this slide, you can show, it's a diagram showing the triage. There is 2 types of patients. Patients came as an inpatient or in the OBD with respiratory symptom or with fever. Those patients directly go or enter the COVID ward. The other patients, if no fever and no respiratory symptom, they will be entered the OBD or the ward as an inpatient if needed, and swab will be taken after admission. Then if it's positive, patient will be referred to COVID ward in the other hospital, specialized hospital, or if negative, they will continue to stay with us with cautions. Okay, next. Challenges faced and lesson learned. Unfortunately, we were having a home care started on July 2019. But after this COVID-19 epidemic, now it's, it's stopped because of loss, there is no resources because of the highly contagious disease, and we have only 2 nurses with us in the home care. We lost one, he's stuck in Egypt. He couldn't return to Kuwait till now. And also the transportation were stopped because they were using application Kareem and a taxi, and it's all stopped in Kuwait because of the total lockdown. So this impacted on us that there is more remote after our symptom management through phone calls from patients and their families, aiming to manage their symptom as much as we can from away from hospitals. Also, we noticed that there is a family anger due to impact of stoppage of treatment abroad of Kuwait. So that's why we have more patients now and less staff in Kuwait providing palliative care to those patients. Thank you.
Thank you, Dr. Amina, for a very interesting presentation. We will move to the second presenter. Happy to introduce Dr. Muhammad Atif Waqar. He's the head of palliative care unit at Aga Khan University Hospital in Pakistan. Dr. Muhammad will share with us their palliative care service experience in responding to COVID-19. Thank you, Dr. Muhammad.
Good morning, everyone. Thank you so much to WHO EMRO and to Sanad to giving us this opportunity to share our experience of providing palliative care in the COVID era.
Dr. Atif, sorry, your voice is a bit distant.
Oh, okay. Can you hear me now?
This is better, yes. Thank you.
Oh, okay. All right. Thank you very much to WHO EMRO and to Sanad for giving us this opportunity to share our experience of providing palliative care in the COVID era in Pakistan. As Naseem already shared with all of you, Pakistan is one of the regions in the EMRO area that was hit hardest by COVID. In fact, to date, we have 270,000 confirmed cases of COVID in Pakistan. So very briefly, I wanted to share with you, the structure and the organization of palliative care in Pakistan. The public health care system, unfortunately, it's not able to meet the needs of the general population. So essentially, most 90% of all healthcare costs, including palliative care, has always been out of pocket. Unfortunately, in Pakistan, we don't have any national healthcare policies, and we also do not have any national healthcare strategies for palliative care. There are no legislations, there are no regulations in Pakistan for palliative care. And even in terms of the curriculum and academia, at the undergraduate level and the postgraduate level, the regulatory bodies, they just don't mandate that palliative care be taught as a required part of the curriculum. In terms of the level of development, as most of the countries in the EMRO region, Pakistan is also categorized as a level 3A country. We've got very isolated provision of palliative care services, very patchy and very sporadic. And the most difficult part is relative to our size of our population, which is close to 220 million. We've got a very small number of specialty palliative care providing services. It was estimated that for every 80 million, we only had one specialty palliative care service that could be provided. So essentially less than 1% of our population in Pakistan has access to palliative care services. Majority of palliative care in Pakistan is provided in institutional settings. It's all hospital-based. What we lack severely is a good home-based palliative care service or home-based hospice services. We do have some freestanding hospices, but they don't provide multidisciplinary care. And in terms of the mix of staff, we've got very few trained palliative care experts nationally, and the palliative care providers predominantly are either oncologists, family physicians, or internists who have a very rudimentary knowledge base and skill set in palliative care delivery. In terms of access to medicines, it's very disheartening, but the access and availability to opioids in Pakistan has been very poor. And that primarily stems from the fact that the regulatory bodies are very stringent with opioids. In fact, we have not one, not two, but actually 4 different regulatory bodies. The Drug Regulatory Body of Pakistan, the Ministry of Health, the Ministry of Narcotics Control, all of them very stringently regulating opioids. So essentially, we don't have opioids available to our patients, even patients with oncological diagnoses. So we end up using very suboptimal medicines such as nalbuphine, buprenorphine, tapentadol instead of morphine to alleviate the discomfort of our patients. As I shared with you previously, we've got a fee for service model because out-of-pocket costs for palliative care are fairly high. And in terms of acceptability of palliative care amongst the general medical community, it's in its infancy. There's still a lot of apprehension. There's a lot of rejection. Often palliative care is viewed as giving in to death and giving up on active treatments, or because it's still a fee-for-service model, the providers are not very inclined to referring to palliative care. They think that we're stealing their patients. So they would much rather hold on to the patients till the very end. And the referrals come in very late. So I work at Aga Khan University Hospital, and we've been at the forefront of developing palliative care in Pakistan. We're very fortunate to have a multidisciplinary team of specialists that are providing palliative care. During this epidemic, our hospital has been open. We've been providing care, and our hospital never closed down. We were providing care to COVID patients. We were providing care to non-COVID patients. And we've been providing palliative care to malignant as well as non-malignant patients equally. We have a very robust inpatient palliative care service that provides consultations throughout the hospital, from pediatrics to geriatrics and including the intensive care unit. We have our own dedicated hospice unit with additional palliative care beds. We have a daily half-day palliative care clinic. We have a very robust home-based palliative care service, the first of its kind and actually the only home-based palliative service in Pakistan, a very large and vast network in Karachi. Because of the lack of opioids, we have a dedicated acute and chronic pain management service, and our colleagues in anesthesia perform interventional pain management for our patients who have very severe pain. And then we've got on-site radiation oncology services. We've got 4 linear accelerators that have been very helpful. We're able to provide a palliative radiation for our patients who have intractable pain and symptoms. So when the COVID epidemic started in Pakistan, we were hit the hardest because being a hospital-based service, most of our patients, close to 70% of our patients who were admitted to the hospital would come through the ER. So we saw a huge influx in the admissions of COVID patients and a huge decrease in non-COVID admissions. And then when the non-COVID patients wanted to come in for care, the ER was completely on diversion and it was completely blocked. So a lot of these patients were deprived care. Beds were not available for them. We did have dedicated COVID units. We had 4 dedicated COVID units of single private rooms, negative pressure rooms, and all of them were essentially completely occupied. So the only way that you could get into the hospital is if a patient died and a bed became available. That's the only way that you could come in. So we saw a huge shift early on from being a hospital-based system to delivering palliative care outside of the hospital and how we could do that. So we had to transition to other models, and I will get to those models individually. But early on, we also realized that looking at the population of patients that would be requiring these services, our palliative care service would not be able to cater to everyone's needs. So we developed a symptom management guideline. This is way back in March when it started. So 2 months before WHO came out with its guidelines, we developed our own symptom management guidelines, and we circulated them institutional-wide. And there was a COVID manual that was established by our institution, and there is a chapter on end-of-life care and symptom management for COVID patients that we had authored. In terms of the inventive use of space and technology, the palliative care services were one of the first to embrace and introduce teleclinics and teleconsultation services. And as I shared with you, even though other services such as the surgical subspecialties had to close down services, we never did. We were operational throughout this course. We also used secure and encrypted messages services to our patients. They were able to send in either video recordings of their loved ones at home or voice messages, or they could take a picture of a wound, or if they needed expert opinion about a skilled nursing care, we were able to guide them with that. We had a 24/7 palliative care hotline service, but we saw an influx of calls that were coming in. But I think the most important thing was when we were able to provide staff-assisted video conferencing at the end of life. So many of these patients that would come in with severe COVID, unfortunately, would die in the hospital, and their loved ones were just never able to see them or hold their hand at the end of life. So our staff were very conscientious in that, and that they would be able to use devices, sometimes their own devices or the patient's devices, and at least be able to show the loved ones before they died in the hospital. In terms of our palliative care training needs, globally, our didactic sessions had to be transitioned virtually and online. So all of our lectures and educational modules, they transitioned either pre-recorded sessions or live Zoom sessions. Bedside palliative care teaching continued because we were blessed that we were never short of PPE. We always had very adequate PPE. So that teaching continued during this epidemic. In terms of staff deployment, we had to be creative and innovative because we deal with a lot of immunocompromised patients, and we had to be conscientious about minimizing risk of exposure to them. So we came up with a simultaneous team model rounding, and what we would do is we would have a team that would provide care to COVID patients, palliative care, and then we would have simultaneously a second team that would provide care to non-COVID patients throughout the hospital. And the way that it would work is that the team would initially start off with the non-COVID care for a week, then they would transition to the COVID unit and provide care over there for a week, and then they would take a week off where they would provide work from home and care from home so that the exposure and the risk was minimized. We were always accessible to the primary teams. Even if we were not able to physically see some patients, we were available by phone to provide guidance and supervision. In terms of access to medications, as I shared with you, we never had any opioids to begin with, so of course we never had any shortages of opioids. But there was one medicine, and Dr. Nella talked about it as well, dexamethasone. As soon as the Oxford study about COVID came out, dexamethasone just all of a sudden became very short. People were stockpiling it. It was readily available over the counter without a prescription. It was being sold in the black market. So we unfortunately had to transition to other corticosteroids instead of dexamethasone temporarily. But now we've got dexamethasone back and it's readily available. Rather than medications, it was more durable medical equipment that we had challenges with because of the vast population. And when the pandemic hit us hard, people even who didn't have needs were buying oxygen concentrators and cylinders and pulse oximeters, and they were stockpiling all of that at home so that the patients who truly needed it, it was just not available to them. We did see a huge influx to the home-based palliative services. We saw a lot of referrals coming into them. And another thing that we were blessed with was that we had support from the state government and from the federal government. Even in lockdown situations, they would allow us to enter, our staff to enter those lockdown areas and provide home-based palliative care. We would show them the credential. We were issued a letter by institution, and we provided care to them. The staff, they either had their own transportation or the institution provided them with carpooling transport so that they could provide care. The shift was that we were providing longer custodial level of palliative care, so 8-hour shifts, 9-hour shifts, but then we had to transition to more shorter visits, like medication administration visits. This is going to be my last slide. I'm just going to finish on this. The challenges that we faced were the psychological toll that physical distances took on us. There was a lot of mistrust among family members, and the reason was, when they were able to see us and meet with us, we were able to show them, empathy, compassion, nonverbal cues, nonverbal gestures. And now we were talking to them over the phone, and they were just, there was a lot of apprehension, and there was a lot of suspicion on their end. In terms of end-of-life care, I shared with you already, patients dying in the hospital all alone without their loved ones was taking a huge impact and a toll on all of us. And then for our staff who were experiencing compassion fatigue and caregiver burnout, we would regularly, on a weekly basis, have these debriefing sessions where they would be able to vent and share their emotions, their thoughts, and their feelings. But now we were not able to do that. We were not able to embrace each other. We were not able to hug each other and let each other know that, this is normal, it's okay. So it started to take a toll on us. The most important thing was DNR patients. Their care was severely compromised, not just in our institution, but in other hospitals as well. Once a patient had that designation of being a DNR, then there was an inclination by staff not to go into their rooms. And because they were in private negative pressure rooms, often the care of the elderly, the mentally challenged was compromised. There was no one to come in to feed them. There was no one to come in to help them with medication. The nursing staff would go in, provide care, and they'd just come out. And in other hospitals, we've even heard some horror stories where when the medical team went in the next day, they found that the patient was actually dead. And they'd been dead for 3 or 4 hours, but just no one went in to check on them. So definitely all of these were challenges which are certainly not unique to Pakistan. With that, I end my talk. I want to thank you very much for allowing us this opportunity. Thank you.
Thank you, Dr. Atif. That was a very interesting presentation. And thank you for shedding light on the role of palliative care teams with patients with COVID. We will be having more insight from all the speakers in our discussion and talked more about this aspect in specific. Thank you again. We'll move to our next and last speaker, Mr. Claude Chidia. Mr. Claude will present the palliative care response in his palliative service at Homerton University Hospital in London, UK. Mr. Claude will share with us how did they respond to COVID-19 and the results of a retrospective evaluation that they did with us. We aim from this international external lens to try to extrapolate lessons learned and experiences to our Eastern Mediterranean region. Thank you, Claude.
Thank you, Farah, and thank you for Sanad and WHO for inviting me. I'm going to share my... Okay, can you see my presentation?
Yes.
Okay, good. Okay, so hello everyone. So I am the purpose of my talk today is just to share our experience in the UK of how we responded to the COVID-19 pandemic as a service. And also I would like to share with you some findings from a service evaluation that we recently completed. So we evaluated the impact of COVID-19 on clinical characteristics, symptom burden, and outcomes of patients referred to our service. So, sorry, I can't move my slides.
It works better when you click on the page sometimes. I don't know if that makes a difference.
Yes, that works. So just to give you a little bit of perspective, so Homerton University Hospital is the region that is highlighted in red. It's located in the London Borough of Hackney, and we provide general health services in the hospital and the community for the population of East London. Street art and graffiti are quite common scenes on the streets of Hackney, like this picture that I've included in my slide, and they tend to reflect the diversity of the population that we serve. So we do serve one of the most ethnically diverse, economically deprived and affected areas by COVID-19 in the UK. To give you a brief description of palliative care services generally and specifically at Homerton University Hospital, so palliative care is generally integrated within the National Health Service in England, and we do provide services in the acute, community and hospice settings. Palliative care service in our hospital, like the majority of services in hospital settings, consists of an interdisciplinary team of health and social care professionals. We are an advisory service, which means that patients are referred to us by their primary medical team that they get admitted under when they come to hospital. In March, we were really hit hard and faster than expected with COVID-19 pandemic. So we had to make changes as we were experiencing the surge of COVID-19 cases. So our emergency palliative care planning really focused on three main key themes. The first one was on developing service capacity beyond our specialist service. And it would be worth noting here that during the pandemic, we were operating on 30 to 40% of our normal capacity because of sickness or self-isolation. Some examples within this theme include, for example, we have developed specific guidance on managing symptoms specific to COVID-19 that was used by all clinicians in all areas of acute settings. We also developed guidance on communication, breaking difficult news remotely as well as face-to-face, and that was circulated amongst all the workforce. We also led on promoting advanced care planning, which was really important in a way that can be shared by all healthcare professionals who might get involved in the care of patients, but including the ambulance services. But also we supported primary care teams and community teams to start having conversations with older people and those identified at risk within their regions, and make sure that their advanced care plans are updated and that they have conversations about their goals of care. We also created an expedited process for discharging patients, especially for those who can be cared for at home. And that entailed working really closely with the emergency team, intensive care team, and our community partners. We also contributed to the development of guidance on managing symptoms specifically for the community, where we used alternative medications and alternative routes because we anticipated that medications and services might be limited during that time. The second theme focused on educating the generalist workforce. So we provided very short and focused teaching on how to manage symptoms, on recognizing dying, specifically in the context of COVID-19. We also created a support system to prevent burnout among across the whole workforce within the organization. And that mainly focused on providing flexible and frequent debriefing sessions across all the wards, but also it included having one-to-one virtual or face-to-face conversations with specific members of the team should they needed to speak or talk about anything. In terms of family caregivers, which is the third theme, what we've done, we have created a communication team on each and every unit. And this communication team really consisted mainly of redeployed staff across the whole organization. So what we've done, we provided very short and focused training for them. And their main role was really to make sure that they contact every single family caregiver for all patients and update them, because we had very limited or absent visiting opportunities to the hospital. And also they supported patients to be connected with their family caregivers through the use of technology. So we made sure to have enough smartphones or tablets on the wards as well. And what we've done is we created some sort of a triaging system where if they identify family caregivers who might be at high risk, they would then refer them to us, because we were not in a position, we did not have the capacity to contact every single family caregiver. We also created a bereavement booklet that was sent either via email or by post to bereaved families, that contained all the services available within the region that they could make use of, but also families were offered to contact us virtually should they need to discuss or they needed any clarification about the care of their loved ones. But they also were offered to have a face-to-face meeting, not now, but once the visitation policy become a bit more relaxed. So this is just a brief description. At the end of April, we decided to do a service evaluation. It's really for us to try and understand how things went, but also to inform our service planning should and when we have wave 2 of the second wave. So the aim of this evaluation was to evaluate the impact of COVID-19 on symptoms, clinical characteristics, and outcomes of all patients referred to us. So what we've done, we've extracted data from the electronic patient records on 60 inpatients with confirmed COVID-19 who were referred to our service between March 1 and April 23 in 2020. And we extracted the same data on another 60 inpatients who were referred during the same time period last year in 2019. So what we looked at, the variables that we looked at included demographics, time from admission to referral or to death or discharge. We also calculated the Charlson and Alex-Sauser comorbidity index scores for each and every patient. And we also looked at the clinician assessed phase of illness at time of referral, and that was characterized by either stable, unstable, or dying. We also calculated the Australian Modified Karnofsky Performance status for every patient. We looked at symptoms at time of referral and the use of subcutaneous infusions and their clinical effectiveness. So the key findings were that the Charlson and Alex-Sauser comorbidity index scores were significantly lower during COVID-19 compared to pre-COVID-19. However, time from referral to death was significantly shorter during COVID-19 compared to pre-COVID-19. And time from admission to the hospital to referral was longer for people from Black, Asian, and minority ethnic groups. And just to say that Black, Asian, and minority ethnic groups might not be relevant to other countries because they might not be, or in other contexts because people might not, or regions might not have that much diversity in terms of ethnicity. But I think it's really important to know that I would say most countries or most regions would have populations that might have similar experience of being marginalized or on the spectrum of being a minority. In terms of reasons for referral, also we found that there was a change. So the proportion of people referred for terminal care and symptom control was higher during COVID-19 compared to pre-COVID-19. Phase of illness, patients were significantly more likely to be referred when they were in the dying phase during COVID-19. So 76.7% of the patients during COVID-19 were dying compared to only 35% pre-COVID-19 in 2019. The use of subcutaneous infusions also were significantly higher during COVID-19, with 43.3% of patients needed subcutaneous infusion to manage their symptoms versus only 11.7% pre-COVID-19, and the majority were effective in managing symptoms. In terms of performance status, it was significantly worse during COVID-19, where none of the patients with COVID-19 infection scored more than 40. In terms of symptoms, the prevalence of symptoms was also higher during COVID-19. So pre-COVID-19, pain and drowsiness were most prevalent, whereas during COVID-19, we had breathlessness, fever, drowsiness, and agitation were most prevalent. In terms of comorbidities, this is a very busy slide, but if you follow the circles, so just to say that before, in 2019, pre-COVID-19, 46.7% of our patients had metastatic cancer versus only 6.7% who were referred to us during COVID-19 had cancer. The most prevalent comorbidities pre-COVID-19 were hypertension and metastatic cancer, whereas during COVID-19, hypertension and diabetes were the most prevalent, especially for Black, Asian, and minority ethnic groups. In terms of implication on practice and implication on research and the challenges, our findings suggest that it's really important to set up responsive, flexible, and integrated palliative care service. But for this to happen, it's really important for palliative care to be part of the COVID-19 pandemic planning response within the organization or the region. And also our findings suggest the importance of early referral to palliative care, especially given the high prevalence of symptoms and the short time from referral to death. And this is also more special for minority groups. And also we've noticed that there were lots of referrals a lot of the referrals came for symptom control, but when we went to see the patients, they were in the dying phase. So that also highlights the need for focused education on recognizing dying among healthcare professionals. In terms of research, our data highlight that there's an urgent need to research why Black, Asian, and minority ethnic groups are referred later to palliative care. And also, it's important to understand how palliative care services have changed, challenges in providing care, and effective solution to set up integrated and responsive services. And also what we've noticed in our data that there was a trend, although it was not statistically significant, for females from Black, Asian, and minority groups to be referred later compared to males. So that highlights also the need to research gender bias in palliative care from an intersectional lens. And finally, I would like to thank the team who contributed to the service evaluation. And thank you very much for listening to me. Farah, back to you.
Many thanks, Claude, for a very interesting presentation and for this detailed lens about palliative care, caring for COVID patients. We will be dwelling more on this aspect in the discussion. So we don't have a lot of Q&A, so we'll move to the discussion and we'll take all Q&As at the end of the webinar. Thank you again for a very variant and rich presentations and experiences. This is very interesting, and we're hoping that in the discussion we can focus on three main themes. How can we maintain functional palliative care services? And the second theme, how can we better meet the needs of COVID patients? And looking forward for ways that we can improve documentation in order to inform policy changes as well. So the nice thing in all the presentations that although COVID situation have impacted countries differently, even in the Eastern Mediterranean region, however, the palliative care response seemed to have a lot of commonalities, mainly such as shifting from hospital-based services to focusing more and more on home-based. And here, the importance of home-based palliative care rise up and shows that maybe this is an opportunity to build on in order to strengthen home-based services. And we also have a lot of commonalities in terms of the challenges we faced. And it's very clear that we were all able to resort to technology solutions. Maybe the challenges might vary, but this is also an opportunity to dwell more on the use of technology and telehealth support, and we will also dwell on this during our discussion. So just to facilitate the discussion and for the sake of time, I'll be mentioning the name of the speaker and mentioning the question, and then we'll be unmuting the speaker. And kindly please also, you can, for the panelists, you can use the raise hand option in order, if you have anything to add, in order to unmute you. So we're already in 5 months now into COVID, and we might be going into a second wave. And if we want to look at how can we maintain the current palliative care services I want to ask Dr. Muhammad Atif about their experience. And now, if you look back, Dr. Muhammad, what is the main element that helped in keeping the palliative care services in Pakistan functional? And what do you think is important to keep it later on, knowing that we might be having a second wave, and you were also hit hard with COVID?
Yes, Farah, I think the most important key part is going to be capacity building. Having enough trained workforce to be able to meet these needs is going to be crucial. There were many times during our service provision as well that our team members were in isolation, were in quarantine, and then that put a huge burden on the remaining healthcare providers because we still had to go out and provide services in some way or form. So I really appreciate the slide that Claude had shared, which focused early on work capacity building and training non-palliative care providers with at least the basics of palliative care, at least primary and secondary palliative care. And I think now would be the ideal time that we engage our colleagues in primary care, in family medicine, in internists and oncologists, so that they can be trained and they can also provide this very important component. The second thing would be PPE, medications, and durable medical equipment. As I shared with you, there were a number of challenges with obtaining the medications that are required for palliation. So ensuring that we have enough medications that our patients can benefit from it, but also the medical equipment that is required to provide palliation. Often those were hoarded by people trying to make a quick buck. So trying to have policies that could ensure that there is going to be medical equipment available to the general population would be really important.
Thank you, Dr. Muhammad. That is true. Maybe to also add on your answer, I was wondering if in Pakistan you had the opportunity to work at the policy level regarding access to opioids or access to important equipment and medications in palliative care.
Yes.
Dr. Atif, we cannot hear you.
He is muted, that's why.
Can you hear me now?
Yes.
Yes, Farah, what I was sharing is that this question is a topic and a debate in itself. Unfortunately, we've had these conversations multiple times before. We've tried to engage the stakeholders, the policymakers, numerous times. Often our pleas have fallen on deaf ears. And we've tried to use other neighboring countries outside of EMRO, but that are very closely aligned to the care that is provided in palliative. So, for example, how palliative care is provided in Bangladesh, how palliative care is provided in India, and tried to use them because they've made huge strides. But at the same time, we have a lot of problems with corruption in our government, and many of the people in such ministries are less aware of the problems that we're dealing with, and not very willing to have this dialogue and allowing opioids to be brought into the country to be dispensed, even though we've assured them of various ways that they can be safely prescribed and dispensed. Thank you.
Thank you, Dr. Muhammad. Yes, these are among the challenges that we usually face in resource-limited settings. And maybe this can feed into the policy webinar, and we try to push through the policy webinar for being more flexible and to paying more attention to palliative care medications and their needs, especially during COVID. Thank you, Dr. Muhammad. I wanted to shed light more on the importance of home-based palliative care services and how can we shift from the hospital to the home, knowing that several speakers said that they tried to do this. And I wanted to ask Dr. Pamela to tell us more that during now and looking into the future, knowing that COVID will continue a bit with us. What are the key elements that help a hospice care service to sustain, and what is the main element that's needed now in order to keep providing the services?
Can you hear me now?
Yes.
So, as you've said, many hospitals-based services try to shift into home-based services. In Sanad, we already are a home-based service, and we are, just for info, we are gladly able to help others if they want to have trainings or we have our own capacity buildings in sharing this experience with others, just between brackets. To say about the needs, just as Dr. Muhammad mentioned, we do need to have a bridge between service provision and policy level. They need to know what are the real needs of the field and maybe raise awareness about the importance of palliative care, especially now during COVID, because palliative care doctors and nurses are the specialists in symptom management. So we need to empower palliative care services and maybe allocate more funds for NGOs maybe, or home-based organizations that are specialized in palliative care, to allocate more funds so we can help them sustain and maintain this activity, and implement palliative care into the policy level.
Thank you, Dr. Pamela. I wanted also to reflect on Dr. Sabah's study along with Dr. Omar and Dr. Tizer and Dr. Richard. In the study, it showed that the number of community-based or home-based palliative care services are already much lower than the hospital-based services. And I was wondering in their study if they were able to look at how if the study included whether the hospital was able to provide home palliative care services, or were they able to shift their model a bit, such as trying to modify a bit the service to better meet the needs. Dr. Sabah, we can't hear you.
So we did have some information on the type of services that are available right now. And there were about, let's say, 10–15% of home-based services and about 20% of community-based care. And in general, there were also those based in the hospital that also had these components, so more complex delivery. But we were not capturing if there is any change at the moment. We were more focusing on how they were prepared right now rather than how they modified. But there is a survey. No, I'm not going to talk about this one. So, thank you.
Thank you, Dr. Sabah. Dr. Omar Shami is as well with us in this discussion, and I wanted to ask him, given his being part of the study and given his experience at King Hussein Cancer Center, who have both the hospital and the home-based models, how was the experience and were they able to shift, or did they not need to shift to start with from hospital to home? Were they able to focus as before on the hospital services, or did this increase the load on the home services, and how were they able to handle it?
Um, Good morning or good afternoon to everyone, and thank you very much for an exciting webinar. I have heard great experiences from people around the countries around us, and really they have shed lights on every important element in really taking care of patients during this COVID-19. For us at KHCC, we were doing almost everything mentioned during this discussion and these presentations. We have seen an influx and increase in our home care services. As you know, we have at KHCC 4 elements of services: the inpatient hospice, inpatient palliative care, the inpatient consultation services, the home care services, as well as the outpatient clinics. Now, we have the model at our home care services, including 4 teams actually taking care of patients, and it's a bit complex and costly model where we have the driver and 2 nurses from KHCC utilizing our institution cars. So we do not rely on third-party outsourcing our cars. The problem that this is a bit costly and limit the number of patients we can see. However, during COVID, we were able to actually double the amount of services provided, and we tried to geographically distribute our nurses where they can serve the same geographic area where they live in. We also minimize the contact among staff workers, so to minimize the risk of transmission between staff workers, as well as increasing the capacity to include patients from remote areas like the governorates of Jordan, around 150 kilometers away from our center. And we were able to provide all the necessary equipments, PPEs, as well as the medical equipments and supplies to our patients, as well as the patients and families. Now, there's very important element which happened during this COVID-19 regarding policy for opioids. Now in Jordan, the policy allows dispensing of opioids for 10 days only for cancer patients, and thankfully that we were able to work with policymakers and our hospital administration to allow dispensing of opioids for more than 20 days or 30 days during this pandemic, especially to meet the needs for those patients who live away in different cities from Amman. And the second important thing that we were able to mail all the essential medications and supplies for patients to minimize the mobilization of patients and family to come to the hospital. So utilizing telehealth for counseling, as well as assessing symptoms and other distressing issues. At the same time, allowing medications and supplies to go to patients' homes. So yes, the thing is, this is a hybrid model. We have the home care nurse at the patient's home, and we have the physician at the other end helping and supporting the patients and families, as well as the home care nurses at home. Lastly, I would like to mention about DNR and advanced directives. In Jordan, DNR, we have to have the permission from the patients and family for DNR. Luckily, during this pandemic, we were able to change the policy a little bit, just to, in case if we have a surge of COVID-19 cancer patients with advanced diseases, that we can move on to DNR without actually needing to have lots of permissions from everyone to utilize to minimize the utilization of ICU beds and ventilation. With this, thank you very much, Farah and everyone.
Thank you very much, Dr. Omar, for a very nice overview about what happened in Jordan. And honestly, I want to build on your answer by mentioning the use of telehealth and move to the second theme that we wanted to discuss. We are seeing that we're using telehealth more and more during COVID, and we wanted to take this opportunity here today to try to dwell on advantages and disadvantages on telehealth and try to see what can be done to further integrate this mode of service and support into the healthcare system, knowing that telehealth is a bit new in the region compared to international countries. So I will start with Dr. Atif as well, because Dr. Muhammad mentioned a lot of interventions that have been using telehealth support and technology. So Dr. Atif, if you can brief us, what are the main challenges that you faced during telehealth support, and how can these challenges help, and how can we meet or overcome these challenges?
Yes, thank you for that very important question. Um, the telehealth is not something new. It's been around for ages, even in the palliative care circles. It's just that it was never embraced by the public, and we can understand why. And for example, in Pakistan, where patients have to pay out of pocket for healthcare, they say if they have to pay the same amount of money, why not just visit the doctor or the team rather than have a conversation over the phone or through the computer? So there's certainly greater acceptance that we have seen during this pandemic. And what it has offered is that it's allowed us, especially in Karachi, to expand our scope of providing palliative care. As I shared with you that geographically, there are not a lot of centers that provide palliative care in Pakistan, but with this model now, we're able to reach very far-flung areas. We can reach very remote areas using teleclinics, and it could be through just a telephone call, it could be a video conference, it could be a WhatsApp or a Skype phone call. All of these are modalities to provide palliative care. The limiting factor, of course, is technology. And in the absence of technology, it becomes very difficult. With phones, phone teleclinics, it's easier because the infrastructure is already laid out, whether it's landlines or it's the cell phone towers. But with video conferencing, it becomes a little difficult because internet coverage becomes very sketchy, very sporadic, and that can be very difficult for patients to do in remote areas. Second problem with the teleclinics is prescribing controlled substances. Now, depending on the law in different countries, some may require a face-to-face visit in order to prescribe controlled substances, and a telephone call or a video conference may not meet that requirement. So that could be a potential problem with prescribing controlled substances. One of the issues that we had over here, and there was a lot of trepidation in Pakistan, was when we would have these teleclinics and video conferences, family members were notorious for invading privacy and confidentiality. Often they would end up recording our videos, recording our sessions, and then they would be broadcast through social media, that when we would have these discussions of breaking bad news, of relating, why their loved one is decompensating so rapidly, immediately we would find that on social media. And there was no way for us to enforce that there would be no recording of these calls. So these are some of the drawbacks, but having said that, the benefits and the advantages are so tremendous, especially in this age and this day, that we should still optimize and use this utility as much as possible. Thank you.
Thank you, Dr. Muhammad. Yes, this is a challenge where technological or telehealth support is not integrated into the healthcare system in terms of having policies that protect confidentiality, platforms that are secure and confidential. So this is definitely a challenge that a lot of other countries might be facing as well. I wanted to move to Dr. Amina, who reported at the end of her presentation. She talked a bit about that due to the COVID, they were more responding to patients through phone support. And I wanted to ask her if is phone support or telehealth support is worldwide, is known in Kuwait? Is it used? Is it being reimbursed? What's the status of being reimbursed in terms of it being it a proper service, or how is it documented if it is? So maybe these are usually challenges that we face here in the region in relation to how are these things documented and integrated into the continuity of care as well.
Yes, Farah, can you hear me?
Yes, Dr. Amina.
Yeah. Telehealth started just in Kuwait with COVID-19, and we use it. We start to use it when we have patients coming from outside Kuwait with cancer patients, and they are in a quarantine. So we decided, how can we communicate with those patients and evaluate them and to titrate their medication, especially opioids and other antipsychotics medication and all this stuff. So we put a policy for this. We communicate with those patients by video calls. They were in the quarantine. There is an attending physician there, and also with us there is an attending nurse. We are not recording the conversation. We just write what is our highlight, what especially was aimed from this calls, like the symptom, other issues, the psychological issues, and also we observe with a nurse, with attending nurse, the facial expression of those patients. It helps, but like counting the respiratory rate, it was difficult at that time. Counseling, it was difficult to express emotions by video calls. It's not an easy way to evaluate. So we record, and we keep recording those things just for confidentiality, and we are not allowing any recording for those things. We know it sometimes people do, but we didn't experience any of those things because we have a witness over the video calls. It really helped us a lot not to lose one of the staff. Might be get infection from COVID patients. So it's really a very helpful technique in this pandemic.
Thank you, Dr. Amina. I was wondering if these calls are usually reimbursed or considered as a service or accounted for in the system, in the hospital itself, or in the healthcare system in general.
Yes, we count it as an OBD visit instead of going there or consultation, outside consultation.
Okay, so yeah, they're finding a replacement to how to account for it.
Counter, yeah, over the
but it's not accounted for as a standalone mode of care, like the visits or the OPD.
Yeah.
Thank you, Dr. Amina. This is maybe this is also, thank you. This is maybe an aspect also to push into the policies, to push for including telehealth as an official service in countries where it is not, or in countries where healthcare system does not account for these services, which is taking care of patients with COVID and better meeting the needs of COVID patients. So I think we all agree, and it's clear from the presentations, that the COVID has increased the need for palliative care, where patients with COVID show severe, a little bit of patients show some symptoms, especially when they are in the severe manifestations related to dyspnea, physical symptoms, or even psychosocial symptoms. And this created more burden on palliative care to accommodate for these needs. As well, this might be also a new platform or new opportunity to better integrate palliative care at non-specialist levels. So here we come to the phase, how can we better meet the needs of COVID patients, talking about palliative care needs. And I wanted to ask Claude here to tell us more about how can this process that you've done, how can we extrapolate this process that you have done into the region? It seems also that Pakistan have done some work related to caring for COVID patients, and we'll also dwell on this with Dr. Muhammad.
Yes, I think, I mean, it's exactly what you've mentioned. I mean, much of COVID-19 from our experience is about managing symptoms, supporting family in crises, providing psychosocial support, and also allocating, helping with allocating scarce resources. And these are all areas that are our expertise as palliative care service and palliative care professionals. I think from our experience, it was really important to build or develop service capacity beyond our specialist service, because it was impossible with the surge of COVID-19 cases to see every single patient. So yes, baseline palliative care being integrated is helpful, but also we needed to do a lot of work in terms of, like, for example, as I said, providing very short and focused teaching, like literally it was 15 minutes as we were providing palliative care consultation. And also being able to be very flexible and respond to the need was very essential. So for example, we no longer waited for referrals. That's how normally our service works. We wait for referrals. So what we've done, we started doing frequent ward rounds, regardless of referrals, to try to identify early on patients with palliative care needs. We started attending multidisciplinary team meetings of the different specialties on the different wards, because no one had time really to think and refer. We just needed to be very proactive and very responsive. But also I would like to mention, despite the fact that palliative care is fairly integrated within the National Health Service in the UK, in the context of COVID-19, the focus was, and I'm not sure if colleagues here would agree with me, there was a lot of focus and attention to intensive care and emergency, which obviously they had a very important role to play. So sometimes we do get missed, or people tend to forget about our area of expertise. But so I do think that there is a role here for us to kind of push for this and remind people. So for example, what we have done, we sent a letter and emails communication across the whole trust, reminding people of our areas of expertise, reminding them how we can help, and also pushing to be part of different committees, working groups, to have palliative care representation, because that was really important to be part of the wider palliative care planning response within the organization, to have palliative care representation.
Thank you, Claude. I wanted also to connect with what you said with Dr. Sabah's findings that were related to how much the palliative care teams were able to support the healthcare system and specific COVID teams. And I remember Dr. Sabah mentioning that 3 out of 5 reported that they had ready protocols and they were ready to provide them to primary teams, and even they're willing to provide trainings as well. So Dr. Sabah, if you can, I was wondering if you were able to analyze this data according to the category of these countries who answered as yes to this aspect, whether these countries were more of a higher integration category in terms of palliative care, which might make sense a bit if they were, let's say, 3B or 3A. So did you have the chance to look at the data this way?
So unfortunately, we don't have enough participants to do that, because it was a rapid survey and it was a bit difficult to access more services. But I could have a quick look and get back to you.
Were you able to get more data other than this, like in terms of were there details about how did they develop the protocols, whether they were using them themselves by supporting the primary teams, or any other thing that can explain more this finding?
So one of the few, so there were not much, it was quite a long survey in the defense of the respondents, so not everybody gave feedback. But for those who shared, they had several people mentioned regional palliative care networks like the EAPC, if I don't make a mistake, or the World Hospice and Palliative Care. I'm not good with acronyms, organizations. So that was one channel for them to get, and somewhere ad hoc policies.
Okay. Thank you, Dr. Sabah. We'll move to the last theme of today. We wanted to try to explore with you more about the role of the documentation. How did you document your care provided during COVID, and how can we better document care provided and the response to COVID in a way that can better inform policy changes? So I know that Claude was able to do this study because of a good documentation system that's available in the hospital. So I was wondering if you can share with us what helped in collecting this data. How did you document the response, and what were the structural basis for this to be able to capture such data and follow up on it?
Yes, so yes, I can say we do have a fairly good electronic patient record that is integrated, and we can, different healthcare professionals can have access to the same documentation. And before even COVID-19, we have implemented as a service outcome measures in palliative care. But to be honest with you, it wasn't great during COVID-19. So for example, we did not have time to look for, to complete outcome measures. Documentation was quick and fast. I mean, there were days where we had to see 30 new patients and there was 1 or 2 people. There were days we had to see 40 patients, for example. So I think having a baseline good record or electronic patient records, baseline or experience in implementing outcome measures, I think that helps a lot. But also, I think it was at the very beginning, because we were really hit hard and faster than what we expected. I think it would be really good, and this is something we learned, that as you on the job, try to think, and especially now we have time to do this, try to think of, should this happen again, which is most likely, we don't know, what are the things from our service evaluation, what are the things that we want to look for that we could not because we didn't have the data. So trying to plan ahead of time, which we did not have the opportunity the first wave, but now we're doing after action reviews and we're looking at what kind of data would be helpful should this happen again that we did not have access to. But yes, of course, having baseline good patient records, outcome measures would help. But even with all that, I can say the documentation was not as comprehensive as obviously it usually is.
Thank you, Claude. I wanted to check if anyone of the speakers would like to provide input on this question. Related to documentation and how can we better improve documentation to inform policy? Yes, Dr. Sabah.
Yes.
Yes.
Yes, I just wanted to highlight that this was for us a big point, a big positive point from the survey, is that most of services seem to have electronic records, which would support this kind of initiative. And most likely, we may only have identified the services that are the most prepared. It's not unlikely, also because we could reach them through our networks. But if there was a network like the one you're building, or other networks, a bit more formal, there would be a great way to share good practices and how they built their electronic record system. Just wanted to highlight on the opportunity there.
Yes, thank you. Yes, this is really important. Yes, and that was a nice finding to find out that many of them had electronic medical system, and maybe they can build on this in order to better improve the documentation and to try to do some changes in policy terms. I think we went over most of the questions we wanted to. We have very few Q&A that we will go over, just 3 questions. The first one was by Mira Abed. She had a question to Dr. Amina Al-Ansari. She's asking if, Dr. Amina, you had any shortage in PPEs provided to staff, and if yes, how did you handle that?
Yes, thank you for this question. At the beginning of the problem, yes, when it started in Kuwait in February, in late February, yes, we have a shortage of PPE. But after 1 month, they brought the full PPE, and now it's available. And also the NGOs donate for us the face shield, the gloves they brought from outside, and now we have enough PPE for all the staffs.
Okay, so you were supported.
Yeah, alhamdulillah.
Great. Alhamdulillah, great. Thank you, Dr. Amina.
You're
Our
welcome.
second question is for Claude, also by Mira. So Claude, for dying patients with COVID-19, were there any expectations such as allowing them to say goodbye face-to-face with their caregivers? And do you think with the spread of COVID-19, such tight restrictions would loosen?
Yes, so what we've done, all patients who were identified as in the dying phase, even at the peak of the pandemic, they were allowed 1 visitor to the hospital, and we provided them with all the PPEs required. But the problem was, especially at the beginning of the pandemic, when we had very little, I mean, we still have little experience, but at the time it was even much less experience. What was happening, patients were deteriorating and dying very rapidly. So you'll have somebody eating and drinking and talking to you, you know, looking fairly okay. And then within 2 hours, they're dying, and then they die within 3-4 hours. So that was really the main problem. So sometimes family caregivers did not have the time to come, and we did not have the time to inform them. But generally speaking, yes, people who were dying were allowed to have 1 visitor during the peak of the pandemic. And now we are updating our policies based on the national guidance here in the UK, and the visiting policies are being relaxed. But okay. Yes, so.
Yes, I think this answers her second question. Thank you, Claude. Our last question is by Dr. Muhammad Abu Raya to Dr. Muhammad Atif. So Dr. Muhammad is asking how you can arrange the need and demand or modifications regarding PC services other than through emergency.
Yes, thank you. That is a very excellent question, because very early on during this pandemic, we were hit by this when all of our patients were being triaged through the ER. Normally, we had a really good working relationship with our ER colleagues, a very well-oiled machine, if I say so. The patients would land in the ER. We would immediately get notified. We would start the necessary treatments, and they would be fast-tracked to our palliative care unit in a matter of 45 minutes. We would see our patients on our floors in our wards. That got severely impacted. And so we had to figure out an alternative on how to provide care for our patients. And we came up with a creative solution. What we would do is we would send out our home care nurses to provide the emergency care, the drips, the medications that are required, but simultaneously they would perform a home-based COVID test. and we would get the test into the system. In 12 hours, we would get the PCR report, and as soon as it was negative, we would have the patient bypass the emergency department and be directly admitted to our palliative care units and beds. And that was a way of fast-tracking it. So I completely agree that there has to be other mechanisms in order to serve these patients and meet their needs other than the emergency department.
Thank you very much, Dr. Muhammad. Thank you all for such an interesting discussion. It was really rich. And thank you for bearing with us, staying half an hour more than the scheduled time. We invite you to join us on Monday for our policy and advocacy webinar, which will be moderated by Dr. Nassim Pourgazian. Thank you, Nassim, for the great support throughout the webinar. And we wish you all a good and nice afternoon.
Thank you, everyone. And it's amazing to see that people have stayed, even if we're 1 hour overdue. So
Yes.
it's really engaging. We will continue the discussion on Monday. A lot of the things we've discussed today, we can build on when we talk about advocacy and policy. And even beyond that, we hope to keep the conversation going. And as I mentioned in the chat, we will share the recordings. We will prepare some briefing notes to summarize what we've been discussing and see how we can use this exchange as we move forward with the palliative care work. Thank you, everyone, and have a good Saturday.
Bye.